two ancient cities of Anuradhapura and Polonnaru in Sri Lanka, big rural areas with large populations of people using pesticides. Is there a mobile microphone or not? Is it reasonably audible when I walk away? Yes. Fine, thank you. So the patients I see are in very under-resourced wards of northern Sri Lanka. But if we come back, this is a painting from the WHO in Delhi, and it shows the rural Sri Lankan doctor in the 1960s when there was an incredible improvement in health and big provision of healthcare into the rural villages. And here you can see him looking after a small child. If you also look carefully in the back and think of this time period in the late 1950s, early 1960s, you see a pesticide sprayer. Because the removal of malaria with DDT in the 1950s, early 60s was an absolute miracle in Sri Lanka. They went down from millions of cases a year to like 11 in 1963. It wasn't sustainable, but at that time, pesticides were part of the medical miracle. Unfortunately, what I work on now is a very different scenario, which is the scenario of acute self-poisoning and self-harm. So is poisoning an important problem? There's a very nice mapping site which takes a fairly typical picture of the world and then represents it according to the incidence of various problems. So if we re-represent this map according to the incidence of self-harm, of fatal self-harm or suicide worldwide, we end up with this. There's a couple of things you'll see that Britain is reasonably chunky compared to other parts of the world. It's quite a high incidence. But what you really see here is China and India becoming massively overrepresented in this. And also, as you see, as I most elegantly point out, is Australia looks like it's being run over. It's a cat run over by a big truck, which I quite like since I have Australian colleagues. So, and why is this? And basically, it's pesticide poisoning. If we look in Australia or in England and Wales, you can see the two major causes of death and suicide are gassing or hanging in both these two areas. And those are, as a medic, there's not much we can do about those. If we go to other parts of rural Asia, you'll see there's a new area, a new color here, the deep purple. And this is pesticide poisoning. And between 65 and 75% of all suicide deaths in these areas are due to pesticides. Now, which pesticide is it? The lovely thing about it, this kind of clinical pharmacology, is the vast variety of different poisons they can take. Go to a shop, you can see a whole variety. Those of you who know paraquat will find that the name, your one shot at life, fairly appropriate if you decide to drink this one. But this is the number one. These are Organophosphorus pesticides. They've all got lovely dynamic names. This is Judo. So Judo 40, or Patas means quick. It works really well. So these are probably the most important problems. So OP pesticides inhibit acetylcholinesterase. As acetylcholine is released presynaptically, interacts with the receptors, and then gets broken down to limit the amount of stimulation of these receptors. You get overstimulation as a result in muscarinic and nicotinic receptors, and this happens in the CNS, the neuromuscular junction, and the autonomic system. If we try and summarize what happens with OP poisoning, we get exposed, which can be ingestion or skin exposure or inhalation, resulting in acute syndrome, acute cholinergic syndrome. With time, there's neuromuscular junction failure, which I'll talk about near the end, requiring long-term ventilation. And also you get the consequences of acute fall in consciousness and acute respiratory failure, which is often aspiration or anoxic brain injury. Consequences of that are multiple patients lying in these under-resourced beds. It's not an intensive care bed, it's an open ward. She's on a ventilator, she's got a monitor, she's got infusions of drugs going in. She's reasonably well cared for, but there's no one-to-one nursing. But as you can see in the intensive care units, in this study, 42% of all patients were poisoning patients in this intensive care in Asia. And that's a fairly common syndrome across these rural district hospitals. The organophosphate patients with ventilatory failure occupy beds. We know the OP pesticides kill around 200,000 people every year. And as we speak now, there are probably 3,000 to 6,000 patients being ventilated for this indication. So is it only a developing world? Are there aspects here? The highly toxic class 1s are not so widely used in the West now, but parathion was used until about 3 or 4 years ago in Germany. And the case fatality for parathion was 40% in probably the best intensive care unit in the world for OP poisoning. They have really well resourced, they got a lot of experience of it, and lots of patients die. And then, of course, we go back to the Tokyo in 1995, when there was sarin was put on the metro station, onto 5 metro trains. But because of problems volatilizing it, they only killed 12 people, which was probably quite lucky since they had something like 12 liters of neat sarin flowing around the floor of these tube stations. A lot of the world effort now is on treating nerve agent poisoning. There's just been a contract from the American military to a company for $235 million to supply an enzyme which breaks down a butyrylcholinesterase, which will break down OP. It's a huge market. What I want to say to you is there's different types of OPs. The OP nerve agents, the sarin, the soma, and the tabun we worry about in a terrorist attack are really highly lethal if they can be volatilized. So 0.1 milligram per kilogram rat oral LD50. We talk about parathion or monocrotophos, the old classical type 1, class 1 OPs. They've got an LD50 of around 10 mg per kg. What I'm seeing in Sri Lanka, and I'll explain why in a moment, is the WHO class 2s with an LD50 of being 100 and 250. So quite a lot safer. And there's a huge difference between this and this. They're basically different agents. And we may be dealing with different syndromes. One thing I'll come back to later on is these are formulated. You drink them as an agricultural pesticide, not as a pure toxic agent. Well, here they're practically a pure toxic agent. So, which is important? We have absolutely billions of dollars being spent across the world on OP nerve agents. And we know in the last 20 years there have been less than 20 deaths. So if you look at $1 billion per death, it's fairly different to what you're seeing with the pesticides. And currently, this is my estimate, 3/4 of patients are dying from class 1s and 1/4 from class 2s, which are less toxic, but probably equally widely used. But in 2002, the Food and Agriculture Organization came out with a statement that we should be banning class 1s because you cannot use them occupationally. It's all about occupational exposure. The fact that people self-harm because it's in their communities and they're faced with it day in, day out when they have stressed lives is ignored. It's the patient's fault that. It's all about occupational exposure being the main problem. And for that reason, probably the class 1s will be banned over the next few years. And that will leave us, well, here's an example of what happened with this. We look at the overall Sri Lankan suicide rate between 1880 and 1952. It was between about 3 and 8 per 100,000. Pretty stable. Then something happened here. And that something was the Green Revolution. It was initiated by an Indian academic, agricultural academic, and it pushed pesticides into people's houses, into communities. And what happens as an easy consequence, an obvious consequence of easy access to pesticides, was this exponential rise in suicide in Sri Lanka. And this was all due to pesticides. What I don't have today is to show you the hanging stayed right down here. But then what happened here was they started banning the class 1s. And so there was a final ban in 1995. And then it was the biggest fall that's ever happened in suicide across the world. And then in 1998, they banned the pesticide they found was a replacement problem in the sulfur. And that's fallen down now to about 20 per 100,000. One man called Gamuni Manawira effectively saved 20,000 lives over a few years by his collected decisions on what pesticides should be allowed to be used. And I would argue that's one of the most effective public health interventions any of us can even imagine doing in our lifetime. So what would happen if that was passed out throughout the developing world? The WHO class 1s would fall to 0, but you'd be left with 100,000 here of the class 2s. So OP pesticides are not going to be going away in the immediate future, and that's clearly stated by the Food and Agriculture Organization. So what I did in 2002 was move to Sri Lanka for 4 years, and I worked in these two district hospitals, seeing patient after patient after patient. So as you'll see here, there are quite a lot of patients. This is our 3 wards, our 3 adult wards in one hospital. Then you can see there's about 12 or 14 patients in one ward, maybe about 10 patients in one, 10 in another, and about 10 or 12 in the women's ward. So 30 to 40 patients any one time in the hospital was not uncommon. And you can see in this column the agents. You can see OP, 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 and then oleander, kerosene, pyrophenol, lots of varied poisons. But we had a lot of work when we were there. It was a fascinating time. And what we did was we had a little handheld database and we recorded them, put them into cohort, put them into clinical trials. And we had over 20,000 patients in the cohort now, of which at least 30% are organophosphorus pesticides. So if we come back to this scenario of OP poisoning and where we might intervene, the obvious first place to intervene is here. It's trying to stop them or stabilize and stop the poisoning coming on, or trying to stabilize them once it happens. And that was where basic resuscitation skills were clearly quite poor. But also there was a big emphasis on gastric lavage and forced emesis. What I'm going to show you now is A, the basic background information. There is no evidence for benefit. And then what I'd like to do is show you one of the consequences, which is aspiration, and how that might have happened. So this is the rule. When you come into hospital for a gastric lavage, you come in with, when you take a poison, you come in with small friends, because big friends lie on you. They tie you down, and if you maybe just missed this guy. There, two little click thugs. The patients keep biting the tubes, which is a little irritating. They try to put water down the tube. So you'll notice they punch you quite often. And you see now they pour water in until the water comes out of the mouth, because then they know they've filled the stomach. I mean, it's easy to criticize this, but it's basically felt like their antidotes are so poor, they've got to make sure the poison gets out of the system as well as possible. And I presume this is not so different to what was going on 20, 30 years ago in the UK. I know in Edinburgh there was a strong enthusiasm for gastric lavage. It was probably done a bit more carefully than this. You can see this girl, she probably weighs about 45 kilos. She's held down by 4 people and she's tied down at multiple time points. The Sri Lankans are very, very good at tying knots, and they've learned with their patients. But the consequences are pretty dreadful at times. I wonder how many of you have seen a fluid level in an ET tube before. And this man died from aspiration of his gastric lavage. And we'd ventilated him with nothing we could do about him. And he took a pretty harmless dose of a carbamate. If he'd been left alone, he would have done absolutely fine. Another patient who was given forced emesis, so giving fluid to drink and making them vomit. You've got 2 options if you take water. This young girl, fit and well, came in, had a tonic-clonic seizure, a blood gas showed a sodium of 112, which we imagine had fallen in the previous hour. I've seen patients come with bicarbonates of 45, because sodium bicarbonate is given to try and induce emesis. But it's a very, very inefficient method if you're not using ipecacuanha. And ipecac is bad news in OPs, because the patients drop consciousness and they're still vomiting. There's going to be terrible consequences. So what we tried to do was change practice away from these 2 very hazardous procedures towards giving charcoal, either orally with patients sitting up unconscious, or if they're unconscious, in the left lateral position, intubated, tubed, and getting through an NG tube. It was not because we believed it worked, but we wanted to see whether it would work, but also we felt it's likely to be safer than the other practices. We did a randomized controlled trial there, 3-way, recruiting 4,600 patients. And this forest plot of 2 of the arms, which is comparing multiple dose charcoal, seeing whether there'd be any effect with elimination rather than just reducing absorption. The overall effect was no effect. We didn't find any consistent effect throughout the various poisons or times. And interestingly, if you look at single-dose activated charcoal, this suggests that it was slightly harmful most times. So likely just to be variation around the mean. If we look at timing of intubation or timing of death, giving charcoal made no difference at all. But the median time to admission was 3 hours. So it should have helped reduce the absorption of oleander poisoning, the seeds of a tree containing cardiac glycosides, with enterohepatic circulation, but we found no effect in that group. So our conclusions here was that routine multiple dose activated charcoal or even single dose charcoal really made no clinical difference there. We found no improvement in reducing and slowing the time to intubation, or even in the patients who arrived very early, within 2 hours, was there a benefit at all. But we came back to this fundamental point. If you compare giving a single or 2 or 3 doses of charcoal to a gastric lavage in an under-resourced situation with too few doctors, it's likely to be a much safer process. So then we come back to the acute clinical features. We wanted to really look at these very carefully in individual OPs, because OPs were generally branded all together, yet there are quite clear differences. So the textbook said patients die from this acetylcholinesterase inhibition. There's nothing else really going on. Everything's down to acetylcholinesterase inhibition. You die from respiratory failure, which is predominantly acute or sometimes delayed, and that's due to a lack of respiratory drive, a failure of the neuromuscular junction, and also fluid and bronchospasm in the lungs. Coformulants have never been proposed to be an issue. and also co-ingestions like alcohol have not been addressed at all either. So we looked at 3 particularly common pesticides. As I said, patas, which means fast, is the method, the chlorpyrifos, benthio, and dimethoate. Now, if I was a mouse who wanted to upset my mother without dying, I'd take something which looks good but is not very lethal. And if I was a mouse, I would take dimethoate, because that's pretty harmless in a rat LD50 compared to chlorpyrifos. That's 3 times more toxic to rats. If we look in our cohort, it's the other way around. Chlorpyrifos is much safer than dimethoate. And it really wasn't very clear why that should be. So we looked at the clinical syndromes and tried to understand what was going on in each of these different OPs. This chart shows us 3 common organophosphorus pesticides and shows the time since ingestion to death. And that's 100 hours. So we say 160 hours is 1 week, 2 weeks, and 3 weeks. And this shows that some deaths are occurring out of 3 weeks. This is really kind of heart-rending. We spend 2.5 weeks ventilating them. We finally extubate them, and they die from pneumonia or PE or something. But what was most interesting was that these patients were dying, the dimethoates were dying early, and not from a respiratory syndrome, but from a cardiovascular collapse. And then these patients were dying late from a delayed ventilatory failure, which I hope I have time to show you some videos of. The WHO treatment recommendations were very simple. OP poisoning is easily treatable with atropine, pralidoxine, which is the classical antidote developed in the 1950s, which effectively rips the organophosphate off the acetylcholinesterase and allows the acetylcholinesterase to work. Excuse me. And then to use benzodiazepines and mechanical ventilation. And in this paper, in 2000, they made a remarkable statement, I feel. No clinical trials are warranted to test the effectiveness of oximes. They work, use them. Based on nothing more than experience in the 1950s in occupational parathion poisoning. Now, the parathion is a highly toxic OP. What I'm dealing with is class 2s. What we're all going to be dealing with over the next 20 years are class 2s, which are less fundamentally toxic. And we already know that's unlikely to be true, that they are going to work for all OPs. Chlorpyrifos is a diethyl, dimethoate is a dimethyl. These are 2 chemical groups. This chart shows the acetylcholinesterase activity in red cells, which is an easy marker, but a good marker of neuromuscular junction and synaptic acetylcholinesterase activity. This patient comes in, it's 95% inhibited, the patient's ill, they give them pralidoxine, there is good reactivation. All of you are here at 600. Normal function is around 600, so they're back to pretty much normal function. But we know consistently now with dimethyl OPs, if you give them pralidoxine, there is no or very little reactivation. These patients often survive because you simply ventilate them. Put them on a ventilator, give them good nursing care, antibiotics for any aspiration, atropine to treat the cholinergic symptoms. But many of these will live. So we set up a randomized controlled trial to try to address the Asian clinical perspective that oximes did not work, and the WHO's adamant viewpoint that oximes worked, and it's stupid to do clinical trials. So in the Asian situation, it was quite ethical to do a randomized controlled trial where we compared no oximes with the WHO high-dose perfect regimen of pralidoxine. We looked at mortality, but then also intubation and length of ventilation. Unfortunately, it was going to be a very big trial, 1,500 patients with 750 in each arm. But a trial was published in The Lancet that I cite reviewed in 2006, which seems to suggest oximes were fundamentally brilliant and saved everybody. So we had to stop the trial early, but we were able to analyze some data. As you see, we only got 235 recruited before the trial stopped. We were able to take measurements of the exact OP that was taken on admission, which no one had done before, quantify it. We looked at acetylcholinesterase on admission, and we looked at aging, a factor whether acetylcholinesterase can respond to pralidoxine. Those were all quantified for the majority of the patients. The first question was, did we give enough pralidoxine? Because half the problems in the past is that insufficient pralidoxine was given. So we looked, the modeling is the green, and the actual concentration we got is the blue. So we gave the correct amount of pralidoxine. Then the next question is, well, we gave the right amount. Did it do what we expected it to do? So these are the diethals, and these are the dimethals receiving oximes. So looking at this patient, taking multiple blood samples after randomization and treatment, you can see the red cell aspartic does not go back up to 600 overall, but there's a reasonable reactivation here. And with dimethyl there's some, but when we didn't give pralidoxime, there was no reactivation. So I would argue this shows we gave the correct amount of pralidoxime and it did what it was supposed to do on the packet. So let's look at the case fatality. The overall mortality was 20.4%, pralidoxime 25%, placebo 16%. If you do a crude estimated hazard ratio, it's just significant. There was some imbalance of stratification as the study was underpowered, so you actually reduce it, you lose statistical significance. But when you take all the patients for which you have the baseline data of exactly which OP they took, and you put into the analysis the amount of OP, the amount of aging, the severity of illness effectively, you get an increased risk. And there it looks like it is statistical significant. So we put that on a forest plot. This is unadjusted. We couldn't find any group, even the diethals, in which we know that aspartic was reactivated. We didn't see any obvious even trend towards benefit. And that was true for every single thing we looked at. And there's a possibility that pralidoxime harms you. And there's another analysis, a post hoc, or actually a predefined analysis of if someone was intubated, did they do well? And what was quite clear that patients who were not intubated when they received the pralidoxime did worse. While patients who were intubated, there was no effect at all. It was actually 1.0 with large confidence intervals, which suggests possibly, and there is cases of it, of pralidoxime inducing respiratory arrest. The problem is OPs cause respiratory arrest. So until you do a randomized controlled trial, it's very hard to tease out what's causing the respiratory arrest. And so pralidoxime and the doses recommended by the WHO may simply be too toxic. So conclusion is, the WHO recommended regimen does not appear to benefit patients with class 2 OP pesticide poisoning. It may be there's significant adverse effects, but there may be other issues like co-ingestions or co-formulants. And that's what I want to briefly come to now. So back again to the acute clinical features. Can we see an effect of alcohol? This is pretty much a pattern from most places in the world. If you look at the number of cases by gender and by age, the peak age is about 20 for girls and about 25 for boys. And then the numbers fall off. Though interestingly in South Asia, men are actually more common than women, every single age group after that first age group, which is definitely not the case here, but it's becoming more like that here. And if we ask ourselves, what do these people die from, the fatal cases? So, if you remember the pattern of the actual cases, the case fatality is pretty consistent with the actual case number, roughly. But what you see is the young people, the young girls, this is only women, they're dying from two things: oleander seeds, which is cardiac glycoside poisoning, and paraquat. And these two are highly toxic in small amounts. Young women do not take large amounts of poison. They often do it much more demonstratively than other people. They'll take it and spit it out, but a mouthful of paraquat will kill you, one seed of oleander can kill you. And so you see older people die from different things. But if we look at men, we see a completely different issue. Instead of having the same pattern where it goes up at the beginning and comes down, we've got a large number of what you might call excess deaths in this middle ground. And while the young people again are dying from paraquat and oleander deaths, here you see this big green area coming and this pale brown, which is the OP, the kind of less toxic OPs where you need to drink more. So middle-aged men are dying in excess. And why? We wondered whether it was due to alcohol. In one study we did, 68% of men were acutely inebriated on admission with self-harm. And we know what they drink is these packets. You go and buy a little plastic bag full of alcohol. It's about 5 pence. And it's God knows how many units in there. And this bottle of arak, it's not arak. This is the firewater. To make a really good firewater in Sri Lanka, you want to make sure your pots are made from cars. So you take yourself a nice car, melt down the engine, make some nice pots and distillery stuff. That gets going. So all the nice contaminants and 30 years of your car engine being running around Sri Lankan roads goes into your stuff. And then you also want to make sure it has a little kind of je ne sais quoi, a little bit of cinnamon herbs, which give you your own little branded. And so to do that, they go to a pesticide shop, buy a bottle of pesticides, put a hole in the lid and drop it in so it kind of decants out as it goes off, and it gives you your own little signature flavor. Unfortunately, sometimes people put paraquat in, and we've had like 25 people dying, going to a wedding, drinking the hooch, and they come in with lung fibrosis 3 weeks later and all die. So you want to make sure you know your purveyor and what their signature little hooch is. Anyway, alcohol, big problem. So what is the role of alcohol co-ingestion in OP pesticide poisoning? My hypothesis was that the more drunk you were, the more you would drink, because you'd lose your taste buds, lose your inhibitions, and that having more alcohol on board would actually make it more difficult to treat you more unconscious, more likely to have respiratory failure. I thought high alcohol levels would make treatment more difficult and outcome worse. So we took 72 patients with dimethoate with a single OP to reduce confounding and measured the plasma dimethoate concentration on here and the plasma alcohol concentration. And you can see straight away that the higher dimethoate concentration you have, the higher the risk of dying. But you also see at the same time, the higher the amount of alcohol you have on board doesn't really have quite such the same. There's not a nice line down here. So we then did some logistic regression. Well, we placed half of these patients had alcohol on board with a median concentration of 1.1, which is a little bit more than the driving limit. Not very high concentration, as you can see, 1.65 with the upper interquartile range. The median plasma dimethoate concentration was higher than those who had taken alcohol. So our hypothesis is possibly correct. You can see 479 micromoles per litre versus 145, and that's quite clearly significant. And there was a positive correlation. The more alcohol on board, the more dimethoate on board. Now that might be due to inhibition of the metabolism, but there's other data which I won't present which suggests it's not due to metabolism is altered by the alcohol. And then if we look at those who died and those who lived, the alcohol concentration was higher in 21 patients who died. If you do a logistic regression, a logistic analysis, you see there's an odds ratio of 4.3 if you have alcohol in your blood of dying. Here's an example of a patient. On admission, 2 or 3 hours post-ingestion, they come in with a bradycardia, a pulse of 15 green, a blood pressure which was probably a little bit low, not too bad, and then the saturation's around 60. They're given atropine on admission, which gives you a nice tachycardia. Your saturations start rising rapidly as your fluid in your lung dries up, but the blood pressure drops away. So here they start dopamine because that's what's available in the hospital. We don't have noradrenaline. We don't have large amounts of adrenaline either. So the dopamine started, and you can see there's a nice recovery in blood pressure. And then it's kind of stable for a while, then starts dropping. At that point, there's an increase in dopamine. The patient has a cardiac arrest at this point, and they start dobutamine. At that point, the blood pressure goes back up, but it keeps falling, keeps falling, keeps falling. Massive doses are being used, epinephrine's being used, but the patient finally has a cardiac arrest. These are patients who just get slow bradycardia, hypotensive, and don't respond to 200 milligram boluses of atropine and require inotropes, which will sustain them for a while. So what I did when I returned to Edinburgh was set up an animal model of this using the mini pig, try to see if I can model this. And what we have is respiratory parameters using Datex. We have a Lidco machine giving us beat-by-beat cardiovascular outcomes. Their own ventilators, and we have Datex, EMG, EEG, and lots of infusion pumps going on. We chose this model because it's genetically and environmentally homogeneous with a very similar cardiovascular system to humans. We do them unfortunately in terminal anesthesia because of home office requirements. We give them dimethoate. So this is formulated dimethoate. When you drink the pesticide you use in your house, you're not drinking pure dimethoate, you're drinking dimethoate plus. It's a white or blue oily substance. And that's what we give them. Then we treat them as we would do a human. Turn the ventilator off and only use the ventilator when they have a respiratory arrest. Looking at the cardiovascular outcomes. So systemic vascular resistance, this is purely due to anesthesia. There's not much change over time, there's a slight tightening. The mean arterial pressure and heart rate fall slightly over time, and the cardiac output stays stable. And we can keep that going for 18 hours quite happily in the placebo-controlled animals. What happens with dimethoate is quite different. What you can see with the first thing you see is a fall in mean arterial pressure, in contrast to the stable mean arterial pressure here, and that requires noradrenaline. We start quite large doses of noradrenaline and try and clamp that blood pressure to around 65 millimeters of mercury. We fail, but that's the target we're going for the whole time. And these are requiring superhuman amounts of noradrenaline. What seems to be underlying this is a vasodilatation, fall in systemic vascular resistance, which falls very rapidly, that within half an hour you're down by 50%, and by 2 hours you're right down the bottom. What happens as a result of this is probably partly tissue hypoxia and also alterations in muscle metabolism causing your lactate to go up. But there's a very clear outcome here of marked lactate production. But what we noticed at the time was interesting. If we look at red cell acetylcholinesterase activity, the pharmacodynamics of the OP absorption, we don't expect clinical features until you've lost 75% of your available acetylcholinesterase. So we don't expect the effect until you're about here. But the pigs only got there at about 2 hours. And yet within 15 minutes they were dropping the systemic vascular resistance really very rapidly. So this seemed to suggest to us that it wasn't purely due to acetylcholinesterase inhibition. And interestingly, the praladoxine dose we gave has no effect on dimethoate as we see in human patients. So we do get a fairly similar model to what we see in humans. So what's the mechanism? Why do you see this fall in systemic vascular resistance when there's no acetylcholinesterase inhibition, or at least insufficient? So what else is there in the dimethoate? We have cyclohexane, xylene, and a surfactant. Now this is a commercial secret, but they won't tell us how much, but they say it's pretty safe, which is why it doesn't have to be on the material data sheet. But if you look at the solvents, they're pretty low toxicity in comparison to the dimethoate OP. So classically, all the toxicity studies have been based on the OP and not on these elements. If you took the dose we're giving to these pigs is 1 gram per kilogram of dimethoate, which is about a human dose, a kind of a large male human dose. So we took what was in that and either gave this dimethoate alone, taking the pure preparation, dissolving in alcohol. They got a decent slug of ethanol, but not a massive slug. And then also cyclohexane alone, giving us a 99% pure technical product. Busy slides, but if you remember the previous slide, and then green's added in for dimethoate AI, and you can see the blood pressure also falls, and it requires dimethoate. But at this area here, it's much less severe. We're requiring much less noradrenaline, as I'll show you with lactate concentrations. And very similar picture with cyclohexanone. A fall slightly delayed with the systemic vascular resistance. That's probably not so severe, but there are some elements of systemic vascular resistance changes. I'm sorry, that's mean arterial pressure. Ignore that comment. We look at systemic vascular resistance, we see the falls. Not quite as severe, not quite as fast, but quite similar. And if we think the most clear one is looking at the arterial blood lactate. So by giving the dimethoate only, we do not get significant lactate rise. And that's partly because the pigs are not so ill and they don't need as much noradrenaline. And the same with cyclohexanone. So is it because the dimethoate's not being absorbed now because of the change in the solvents? But if we look at the pharmacodynamics, we can see it's pretty much identical. And the pharmacokinetics are as well. So the dimethoate is being absorbed despite the absence of the solvents. What we haven't done yet is measure the cyclohexanone. Perhaps there's alterations in cyclohexanone absorption in the absence of the OP, and that will be measured. So the obvious thing to do then was take the dimethoate and the cyclohexanone and add them back in together and see what we get. This is putting the dimethoate AI to show you again what it was like in the past. We got a very similar fall in mean arterial pressure that again required large doses of noradrenaline to try and keep it up above 65. Just carry this, please. But really quite striking was systemic vascular resistance change. The combination of the two together gave us pretty much an identical fall in systemic vascular resistance, which is quite different to either cyclohexanone or the dimethoate alone. And again, when we look at the lactate, until one pig was extremely ill, which is why there's a quite large standard deviation here. When that pig died, it fell away. Otherwise, the lactate was identical when we put those two products back in and compared it with the dimethyl EC40, the commercial product. And quite different to what we see here. So looking at the dimethylate and the distributive shock, it seems clear that it's not just the OP that's causing this, it's a combination of the cyclohexanone and the dimethylate AI. And that's due, I think, partly because to take a dose of the dimethylate, which kills you, you need quite a large dose compared to the parathion. The parathion is more toxic, and so you can die with reasonably small doses. When you take the dimethylate, you need much bigger doses, and therefore there's a bigger amount of solvent there. So what we need to do is look at human studies to test this. But if it's true, if we can make dimethylate safe by changing the solvents and make it agriculturally equally effective, you could save tens or hundreds of thousands of lives across Asia over the next decade by simply changing the formulation. I've got a meeting with Cheminova, the pesticide company that makes dimethylate, in January, where I hope we can start initiating that process. Okay, just the last sections then. I want to look at the neuromuscular junction. If we look at the timing of respiratory failure, it comes back to the point that OPs are very different in the timing and the cause of respiratory failure. With chlorpyrifos, the time to intubation is pretty much either before or on admission to hospital. Look at the Venn diagram. 71% of all ventilations occur in the first 4 hours. Compared to fentanyl, very few occur early, the majority occur late. And you can see that here, that only 7% occur in the first 4 hours. 14% occur in the first 4 hours, a few in the next few hours, and in 24 hours, the great majority of respiratory failure occurs. Now, this is due to the intermediate syndrome. Look at this man's neck. He's trying to lift his head off the pillow. Okay, he cannot lift his head. He's lost all power in the flexors of the neck. And this is the first feature you'll see of impending respiratory failure. He's talking, do a neurological examination, cranial nerves are all working beautifully, but he can't lift his head off the pillow. So one thing we do every day is go around 2 or 3 times, put your finger on the forehead, and can they push your fingers away? And if they can't, you start doing what we do next. Could you just start this video, please? Hello? So what we then do is look at tidal volume to try to measure this every 4 hours in these patients. And what you can see, if you follow the down, he's got very good ventilation at the moment. Those are superb tidal volumes. But of course, what happens next is I found him next morning hyperventilating, using all his accessory muscles, and he's now intubating. He's intubated for 2 weeks. As he's lost he's fully conscious, but what he's losing is neuromuscular junction function. Wadia, a consultant called Rustam Wadia, who's a neurologist working in Pune in India, first described this. It was then more formally described by Senanaika in New England Journal of Medicine in 1985. It's quite common. Why it happens, we don't know. But the treatment is ventilation, and treatment's effective. You can keep people alive by ventilating them. But clearly in these scenarios, you've got lots of risk of ventilatory pneumonia, of pneumothorax, all the problems you might expect from ventilation. So you don't want patients to be ventilated. So we came back to our pig. What we did was set up mechanomyography, which I don't have a video of it, but what you do is a train of 4. You expose the nerve in the hind limb, stimulate it 4 times, and measure with mechanomyography the twitch in the muscle. You do it 4 times. It's basically a standard anesthetic approach. And you can see here 4 nice big twitches, which over time, with anesthesia, fall maybe by about 20%. What you see with dimethylate is it falls off by 6 hours, and by 12 hours you've lost completely your neuromuscular junction function. It's always been presumed to be due to overstimulation of the neuromuscular junction of the postsynaptic nicotinic receptors with subsequent downregulation. But it does take 2 weeks to recover, so something's really severe is happening here. You can just look at 2 aspects here, one of which is the fade, the T1, looking at the height of this one over time. This is just 2 pigs, a control pig and a dimethylate pig. You see it falls off gradually over time. And then you can actually compare the T1 to T4, which is more a presynaptic element or fade, and you can measure that as well. But when you put dimethylate AI in, the active ingredient alone, you don't get an effect. So this is quite remarkable. The idea that it's actually a combination of the solvent and the dimethyl OP causing this dysfunction to occur. That, again, has not really been proposed before. And if, that just shows it again, you don't get these changes. And it's consistent. One of the things I do with these pigs, or Jonathan does with me, is we open up the pigs as soon as they've died. I take the phrenic nerve under a stimulator, stimulate the phrenic nerve, and see whether the diaphragm twitches. And when you have failure of the leg neuromuscular junction, you have failure of the diaphragm as well. Where you don't, and here just one animal of the 4 had a twitch. So what we've gone in is done immunohistochemistry and electron microscopy of these neuromuscular junctions. Now, the green staining here is neurofilament here, showing the axon, and here it's synaptophysin, which is a protein on the vesicles presynaptically. So it labels the density of the vesicles. And what you can see here, with the red, is alpha-bungarotoxin labeling the acetylcholine receptors postsynaptically. So where they coincide, you get the yellow staining, and you can see that at this neuromuscular junction, you've got postsynaptic receptors and presynaptic synaptophysin. This has been altered. The strength of the various components have been altered to show that there's no destruction of the neuromuscular junction. It looks generally okay at this level, and you can see that the red and the green coexist in the same places. But the green is massively reduced. You can do it quantitatively using pixel counts, and there's a fall of around 90% in the synaptophysin expression in presynaptically. When we look with electron microscopy, we see a really interesting finding. Here's the presynaptic bouton, full of vesicles. Here's a poison pig. There's only about 1. You can actually count the vesicles. There's 3 here, 2 here, they're here. They've lost the vesicles. And in addition, the terminal bouton is much larger. So what seems to maybe be happening is overstimulation. The vesicles are going into the neuromuscular junction, releasing the acetylcholine, but you run out of your ability to re-encapsulate your neuromuscular junction, your vesicles. So the study we're trying to do now, we've always thought about previously blocking the postsynaptic receptor in this model to see if we can prevent these changes occurring. But now we're saying, well, actually, we need to think about the presynaptic one. So the alpha-3 beta-2 receptor here we can block with D-tubercularine. And if I can set up a mouse model in the future, we can use a conotoxin 3M, 2M. So overall, I'm sorry if this is a little bit rushed. It's about on time. OP pesticide poisoning is really very highly variable. It's not what we expect it to be. The classical antidote really doesn't seem to work, at least for the class 2 OPs, where the very large dose of OP is required with a correlating large dose of solvent. If you take a parathion, where only, say, 10 mils will kill you, that's only 5 mils of solvent compared to 50 or 100 mils in these patients taking dimethoate. So therefore, the balance between the solvent and the OP may be quite different in the classical type 1 OPs, which are going to be banned very soon. The cardiovascular and I think neurological toxicity is due to the solvent and the OPs, and the intermediate syndrome appears to be due to presynaptic injury and not postsynaptic. So if we come up with a drug which we can use in these patients to protect the neuromuscular junction's nicotinic receptors, using rocuronium or D-tubercularine, something like that, we may be able to find a way of protecting the neuromuscular junction until the OP is out of the system. My work, what I talked about today is the kind of animal work and the clinical. If we can halve the deaths from pesticide poisoning worldwide over the next 10 years, we can save about 150,000 deaths a year, or lives a year. But it's going to involve taking the research we're doing and working with the policy people. So I'm doing public health clinical trials as well. Took me there the first time to work on snake bites. There was actually very few snake bites at that time, so we were actually looking at poisoning because there were so many more poisoning patients coming through the door. And one of the doctors said to me, snake bites all well and good. If you work on poisoning and try and solve that for us, that'll make a huge difference. And it was kind of a stimulus to start doing all this work. And clearly I need to thank very much David Webb and Nick Bateman in Edinburgh for all the support they've given me over the last few years, and my superb collaborators for the mini pig work. Thank you.